Now we're going to be talking about ulcers, and I like this picture of the stomach and the esophagus and the duodenum because it kind of gives you a picture of where the ulcers can be in the GI tract, as well as how deep they can go. You look at the mucosa, the submucosa, and it's almost to the musculature of the stomach. We can have primary or idiopathic ulcers that occur in the absence of any underlying disease. We can have secondary ulcers that tend to be acute in onset. They occur usually in conjunction with some kind of serious illness or use of nonsteroidal anti-inflammatories, and those are more often you see those in the stomach versus the primary you see mostly in the duodenum. Our etiology, there's some known factors that can alter the mucus, that mucus bicarbonate barrier in the stomach and the duodenum, and they include, you can have a gastronoma, which will excrete excessive acid secretion, or hyperparathyroidism. That increase of calcium can also increase the risk for ulcers. Bile salts break down the inherent mucus structure of the gastric duodenal lining and expose the mucosa to acid. Prostaglandins deficiency may cause impairment of the mucus bicarb barrier. Duodenal ulcers show a familial type tendency. H. pylori is a gram-negative spiral bacterium that has been identified in the gastric antrum of children with duodenal ulcers. Physiological stress accounts for most of the secondary ulcers that are encountered during infancy and early childhood. Medications, aspirin, NSAIDs, indomethacin, tobacco, alcohol are also known to affect the gastroduodenal mucosa. Diet does not seem to influence the development of ulcer disease in children, although some certain foods may cause indigestion, such as colas, teas, and chocolate. However, increased acid secretions may be contributing factors as well. So the incidence is unknown because ulcers often spontaneously heal, usually before a diagnosis is made. Usually only 5 to 7 children are diagnosed with a gastric or a duodenal ulcer per 2,500 hospital admissions each year. And H. pylori has been found in about 80% of those. Secondary ulcers in children occur as a result of NSAID use or physiological stress, especially associated with a critical illness such as severe burns, sepsis, shock, or an intracranial lesion. Just keep in mind too that when children are sick with viral illnesses, they can become really, really sick, and that may also be a cause of ulcers in children, which you don't really see that much. So the symptoms in children are burning, cramping, pain, especially when that stomach is empty, and then they start eating, and then it's better for a while because the acid has something else to kind of eat at. So what will happen when they eat, they'll feel a little bit better, but then after the food has been digested and gone down from the stomach and the duodenum, then the ulcer will start acting up again, and they may or may not throw up. Awakening during the night is another, or early morning with abdominal discomfort, vomiting in children younger than 6 usually, and you can either see hemoptysis or melena are very common in the infant and the young child. How we diagnose this is upper endoscopy, and that is the ideal. Make sure that you check the stool for occult blood, and then we manage them by a bland diet, they used to think that milk and small frequent meals was the mainstay of ulcer therapy. However, the protein and the calcium in the milk usually stimulate more acid secretions than they buffer. So they recommend now that a regular diet low in caffeine is now prescribed. And a diet high in fiber and polyunsaturated oils may also play a role in ulcer prevention. Medications are now considered the first line of treatment. They include maybe antibiotics, especially if it's H. pylori, proton pump inhibitors, your H2 receptor antagonists, and the mucosa protective agents. And usually it's a 4 to 6 week treatment, especially to eradicate H. pylori. Surgery is another. If it's really, really bad, they'll usually do a vagotomy and pyeloplasty and ligation of any kind of bleeding vessels if that happens, and they can usually do that through endoscopy. It's important on your nursing assessment to get a thorough history, and especially get a thorough history of how the patient is eating and when the child is throwing up, when is the pain worse, when is the pain better. That's very important. Also, examine the child for any tenderness, epigastric tenderness, that nausea and vomiting. Make sure that you hemocult and hematest both of those. If there's any abdominal distension, melena, and what's real important too is to assess for dehydration. In your book on page 428, it goes that patient-centered teaching, the care of the child with an ulcer. So I want you to go over that. It's basically that the parent and the child need to understand the patho, the causes, the diagnosis, and the therapeutic management of the ulcers. Emphasize the relation of the ulcer to that acute illness. If a child is older, identify sources of excess stress that can be modified. Teach relaxation and exercise, and refer the parents to any support groups. And make sure to not administer antacids within 1 hour of other anti-ulcer medications. Do not stop the meds, very important. Do not use aspirin or NSAIDs because they can cause bleeding. Do not use any over-the-counter medications without letting the doctor know. And do not add any other drugs to your patient's diet or regimen. Provide meals and snacks every 2 to 3 hours, and make sure that the child avoids any coffee, chocolate, caffeine, any other foods that might cause any kind of discomfort. And the complications, you want to make sure that you instruct the patient to call their physician if the child experiences any coffee ground vomitus, weight loss, those tarry black stools, increased pain, diarrhea, or vomiting. We're going to talk about IBS, irritable bowel syndrome. I've been having a really hard time and being tongue-tied this morning, so worse than what I normally am. So I just want to just kind of preface that because I've done this 4 times already and have really messed it up. So just bear with me, and we'll talk about irritable bowel first on this session. And let's go back to our other slide first. Okay. IBS is a condition that's characterized by chronic abdominal pain that's associated with alteration in bowel habits. This increased intestinal motility can lead to spasming, it can lead to pain, and so when we look at the reason for it, then we know that we're going to be given antispasmodics for these children, or even for adults who have IBS, and one of those would be Levsin, or Donatol. So those are the kinds of things we're going to treat with it. The etiology, stress, especially children. You know that children can have recurrent abdominal pain, which isn't unusual, especially in the child that's older than 6. In many cases, the cause is just unknown or unexplained. The symptoms can resemble those characteristics of irritable bowel syndrome. So our exact etiology is not understood, but it's believed to be triggered by those stress, emotional factors, or infection. There's other risk factors such as family members with a similar GI disorder and history of childhood sexual abuse, which is important, especially if a teenage girl or a boy or school age come in and you cannot figure out exactly how come, and you've done your abdominal ultrasounds, you've done your x-rays, make sure that if the condition permits and the symptoms permit, make sure that you may have to do a pelvic or question the teenage girl or boy, alone without the parent in there, and see if there's any type of sexual abuse going on. So that's important to remember. So on diagnosis, we basically are looking at ruling out other disorders such as Crohn's disease, Giardia, lactose intolerance. We can do an abdominal ultrasound, stool for O&P, cultures, abdominal x-rays, and as I mentioned before, we need to do a complete gynecological assessment if age appropriate, and that's often ordered, especially if they think that there is a problem with a sexual abuse. So there's no definitive treatment goals aimed at identifying and reducing triggers, reducing the bowel spasms, which we talked a little bit about before. Diet is healthy, well-balanced, moderate fiber, lower fat. Encourage the child to eat slow, no carbonated beverages, no juices. And our medicines, we'll use the antispasmodics such as Levsin or Donatol, some antidepressants. We have to just make sure that the child can take those, depends on what age. Some SSRIs or tricyclic antidepressants are sometimes used. So usually the prognosis is pretty good with these children, as long as we know exactly what is causing the underlying problem with whether it's a psychological problem, whether it's maybe school, emotional events, any kind of stress in the family. And as we all know, there's a lot of stress in our families. So those are all things that we would need to assess when we have children with IBS. Okay, that's it for that. And we'll conclude and go on to the next